would like just Samia to, yes, to just start recording. Thank you. Okay, so welcome everybody. Welcome. Thank you for joining us for our the Poison Hour webinar. Today we will be talking about too hot to handle, basically managing the hyperthermia in ED. My presentation is to be honest, is quite long, but however, I'm going to focus on the most important relevant, slides to our practice in the emergency department. So I would start, this is just an overall view of what I'm going to discuss on today's presentation, but let's go ahead and start. So I want to start with this case presentation. We have a 74-year-old male brought to the emergency department with a history of altered mental status and excessive sweating. So basically 1 hour before the presentation, family said that while they are in the route, he had this rigid movement in his bilateral upper and lower extremities. He had some also lost consciousness on the way to the ED. Just a quick questions to all in the emergency department. He had these vital signs. Blood pressure was 116/64. Heart rate, he was a little bit tachypneic. Blood temperature is 41. Respiratory rate is 28. Saturation well in room air. Physical examination, the patient appeared to be in a deep sedated and lethargic. There was no response to a painful stimuli, and there was like diffuse rigidity was noted in all the limbs. So I will going to next. So just this is like, I'm gonna pause very quickly. I want you to give me your diagnosis and what will be like, what is your differential diagnosis, what will be done next, and how would you like to manage this patient? Briefly, if you can share your thoughts through the question and answers bar, it will be good. While this is happening, I just need to modify my view. Just gonna end the slide quickly. I'm sorry for that. Okay. 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 Okay, good. So we have here someone saying sepsis, NMS, rigidity in the picture. Okay. Neuroleptic malignant disease. History slide, please. Sure. We'll go back to this. So this is the history slide. Mainly altered mental status, excessive sweating, rigid movement, and bilateral upper and lower extremities movement, and LOC and the ED. This is his physical examination, and this is his vitals. Good. We have here a serotonin syndrome, NMS, serotonin syndrome, heat stroke. Good thought of process of thinking. Okay. So let's go next. So I'm not going to answer what was this case. By the way, this is a real case, was reported at Minatox clinical rounds from Lebanon. But I'm not going to talk about this case. We're going to discuss this case at the end of our presentation. So I want to talk about the physiology of thermoregulation, because this is what we are talking about here today, is about managing the hyperthermia. So usually thermoregulation happens at the hypothalamus centrally through the sympathetic and parasympathetic stimuli, mainly the sympathetic stimuli, with norepinephrine, dopamine, serotonin as the neurotransmitters in this process. Usually what happens is that when we get exposed to a cold environment, the hypothalamus will send signals to the muscles to stimulate involuntary contraction movement, which it is what we call it shivering or chills, and at the same times it will also stimulate the hair follicles, giving goosebumps, so to trap more air around the skin. And at the same time, it will lead to what vasoconstriction, so it can preserve the heat in the body. On the other hand, when we have, the body get into a hot environment, what will happen? The hypothalamus also will send signals. These signals will be sent to the sweat gland. So basically, we'll start to sweat more, having diaphoresis and evaporating the heat. At the same time, the hair follicle will be more relaxed, that to dissipate the heat from the body. And on the other hand, we'll have vasodilatation of the blood vessels. So this is important, I mean, to cover this part, because understanding this part, we will know why do we have hyperthermia induced by different drugs. And as we know all that usually the body regulate the temperature to be around 37 Celsius. So let's go next. So what is hyperthermia? Hyperthermia is any temperature exceeding 40 degree. And basically there are so much factors can contribute to this, such as infection, sepsis, heat stroke, which is both could be external or exertional, non-exertional, toxin that induced hyperthermia, which actually in my presentation, I will be mostly covering these two. We have also primary hypothermia caused by other lesions or other causes, such as hemorrhage, intracranial hemorrhage, or epilepsy. Also, withdrawal of alcohol and sedative hypnotic or opioid may cause hyperthermia. And then we have the pheochromocytoma and thyrotoxicosis as well. So it is very important to talk about heat stroke when we talk about drug-induced hyperthermia. And I will let you know later on why it is important. So heat stroke is identified, it has two definitions actually to heat stroke. It is either a rectal temperature greater than 40 degree in the setting of neurological disturbance, which is manifested by mental status changes such as confusion, delirium, stupor, coma, or convulsion. Or the other definition of heat stroke is any type of hyperthermia, regardless of the temperature, but it is more than 30, of course, what I mean regardless of the temperature, I mean more than 38 Celsius, with systematic inflammatory response syndrome leading to multi-organ dysfunction, and encephalopathy should be the predominant in this. This is another explanation. That's why why this is important, because sometimes, especially in the summer, that you will have patient coming to you because of heat exertion, and maybe they are in heat stroke, but not necessarily their temperature is 40 degree. Sometimes they could have a temperature of 38, but they are confused with decreased level of consciousness. Keep in mind that this is actually a heat stroke, and this patient should be treated well. So clinical symptoms of heat stroke can actually vary, but usually if it was not treated in a timely manner, it can lead to encephalopathy, acute renal failure, hypotension and shock, and DIC. It can also lead to myocardial injuries, hepatocellular injuries, acute respiratory distress syndrome, and intestinal ischemia. So why do we need to know about heat stroke? When we are talking about mainly about actually drug-induced hyperthermia, it is extremely important to understand the heat stroke because of several factors. One of them is that most of the studies that are done on hyperthermia, it was done actually on heat stroke. This is one reason. The other reason is that the body response to an elevated core temperature is similar across all the types of hyperthermic disorder. So that's why it's important to understand heat stroke. The third reason is that most of our strategies of treating hyperthermia induced by drugs is actually based on studies that done on heat stroke. Let's go next. So this is an interesting studies that was done actually, it's a retrospective studies, to be honest. It was done in Arizona. In Arizona, where more or less they have similar climate to us because they are like desert area, and it was done to assess the outcome of patient after environmental hyperthermia, and it was done in 2003 and 2005. They included 52 patients. Interestingly, that the mortality rate, keep in mind all of these patients presented to ED and they received management. So the mortality rate was almost 30% of this patient died. And the things is that what they did basically, this was a retrospective review of medical record of this patient. What they found that odd ratio was significant odd ratio on this patient who presented with these parameters. So patient who presented with high temperature, high body temperature of more than 42 degree or more, they had higher mortality rate. Patient who presented with low systolic blood pressure of around 90 and below, and patient who presented with low GCS around 12 and below had significant predictor of mortality rate. So that's why it's very important to identify hyperthermia, and it's very important to treat hyperthermia because its mortality rate is extremely high. Okay, so let's talk about major syndrome that can cause hyperthermia in toxicology. I want to start with this first case. We have a 32-year-old man brought to the emergency department by his friends because of severe agitation and restlessness. The friend reported that the patient was awake for almost 3 days, talking rapidly, acting suspiciously. On arrival, he was sweating profusely, pacing around, and appears extremely anxious. Vital signs: he's hypertensive, he's tachycardic, he's hyperthermic, and he's tachypneic. Physical examination is reporting dilated pupils, dry mouth, and tremors. No signs of trauma were noticed. And when you talk to him, he's saying people are following him. What is mostly likely the presentation? I want you to answer in the question and answer by A, B, C, or D, or E. What do you think?
We have one answer, C,
Okay,
phencyclidine.
PCP. Okay, what
Mhm.
else? What about the others?
B, methamphetamine,
Okay,
crystal meth.
good. Okay,
We have E.
serotonin. We have A. We have diphenhydramine. Okay, I like the answer. There's variety of answers, which it means that this presentation is very important presentation. So we can
Yeah,
understand
mostly it's
and
A
see it.
and B.
Okay, good. Mostly is A and B. Okay, that's good. So actually the correct answer in this case is actually this is a methamphetamine intoxication. So let's talk about stimulant. So let's talk about sympathomimetic syndrome. So sympathomimetic syndrome, it can be like xenobiotics of different drugs. It can be from amphetamine, methamphetamine, MDMA, cocaine, or mouse inhibitor. Okay, so what is the mechanism of action of this sympathomimetic when it comes to hyperthermia? So what it happens actually is that I'm really sorry. Okay. So what happened is that it caused central deregulation of the thermogenesis through what? Through excessive release of serotonin and dopamine. This is one thing. It will cause as well direct and indirect stimulation of the hypothalamic pituitary thyroid adnexal axis, leading to increase the circulating thyroid and adrenal hormone in the body. By this, it stimulates the entire body. Okay. And also it has a catecholamine mediated vasoconstriction, which actually will inhibit what the dissipate of heat, which we said before, that when as part of the thermoregulation, that when the body is exposed to a high heat, the hypothalamus will send signals to what? To the blood vessels to vasodilate. But here, unfortunately, this reflex of the body, it will be inhibited by the sympathomimetic drugs. The other things also with the sympathomimetic drugs, other than acting centrally and peripherally, inducing hyperthermia, it also will over contribute to the hyperthermia is the psychomotor agitation that most of these patients will have due to either increased muscle activities or seizure. Okay. Let's go next. So what are the symptoms you will expect? You will expect to have like mydriasis, diaphoresis, hyperthermia, hypertension, tachycardia, tachypnea, increased bowel sounds. Usually, how do I always like connect sympathomimetic? Sympathomimetic, everything is actually agitated, everything is increased, blood pressure is high, heart rate is higher, respiratory rate is higher, eye is dilated, is bigger. The GI symptoms, the GI or the bowel sounds are increased. Everything is increased. This is how I always remember sympathomimetic for just to make it easier for you. Okay, so how would you treat the sympathomimetic? Of course, the mainstream of treatment is actually aggressive cooling because what would kill the patient? Okay, so this is a good question. In sympathomimetic or even in serotonin or even in the other like syndromes that we will talk about, what is the killer of the patient? What could kill the patient? This is just a question. I want to know your thoughts. You can share your thought in the question and answer. Okay, excellent. It is hyperthermia. Hyperthermia, what would kill the patient? Rhabdomyolysis can cause AKI and you need to treat it. However, hyperthermia, what will kill the patient? So treating hyperthermia is your main goal. Okay, what else you would give? Supportive treatment, and then of course you can give benzodiazepine, barbiturate, muscle relaxant, and severe agitation. Let's go next, because I need to keep up with the timing as well. So this is our second case. Just to go through the case quickly. We have a 19-year-old male college student brought to the emergency department after collapsing at a summer musical festival. His friend says he has increasingly restlessness and confused during the day, and he was complaining of feeling very hot and thirsty. So they mentioned also that he was feeling unwell for the last few days and he was taking some medication over the counter. On examination, he appears disoriented, agitated, frequently pulling at his clothes. Vitally, he was mildly hypertensive, tachycardic, hyperthermic, and tachypneic. Physical examination, his skin was warm, flushed, dry to touch, pupil dilated, mucous membrane are dry, and bowel sound diminish with full bladder. So what was best explaining the symptoms? Is this A, heat exhaustion, B, serotonin syndrome, C, cocaine intoxication, D, anticholinergic drug toxicity, or thyrotoxic crisis? You can choose A, B, C, D, E.
We have D. 3 responses.
Okay, so actually you are right, it is D. This is an anticholinergic. Okay, so let's talk about anticholinergic. Anticholinergic drugs is like a group of drugs, like antispasmodic has anticholinergic effect, antihistamine has anticholinergic effect, anti-ulcer drugs, anti-Parkinsonism drugs, neuroleptic drugs have. Keep in mind that most of antipsychotic drugs, they have anticholinergic effect, including the TCA, by the way, have anticholinergic effect. So let's talk about the mechanism of toxicity. Usually, the anticholinergic drugs will cause hyperthermia centrally and peripherally, and this is through muscarinic receptor blockage, where central effect depend on the drug blood-brain permeability, and peripherally, the anticholinergic will block the interferes with what continuous loss of heat. That's why these patients are dry and basically they cannot sweat to release the heat, and you can see that they are flushed red. Why they are flushed red? Because there's vasoconstriction, which shouldn't happen, which actually disturb thermoregulation, and this will impair patient from sweating and impair patient from dissipating the heat. We have also what will also contribute to the hyperthermia in this patient is the agitation and seizure, which it can be developed in severe overdose. Okay, so let's talk about pneumonic. So pneumonic is usually it is hot as a hair, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. So usually, what symptoms would you like expect? There will be also mild races. There will be like altered metastasis. There will be tachycardic, hypertensive, tachypneic, dry mucous membrane, flushed skin, and there will be urinary retention and constipation. So how would you differentiate anticholinergic from sympathomimetic? We'll talk about it later on, but you can share your ideas about how would you differentiate. So what is the treatment? The treatment is actually mainly it is supportive treatment. However, you can give physostigmine. Physostigmine you can give 1 milligram to 2 milligram per hour intravenously. And the main treatment I would say again is external cooling if you have hyperthermia with it. Okay. So any answers? Okay, I can't see any answers, but just to keep on the time, because so how would you differentiate between sympathomimetic and anticholinergic? They have a lot of similarities. However, the difference is to differentiate between sympathetic and anticholinergic. Anticholinergic usually they are dry, sympathetic they are wet. They have a hypoactive bowel sound, and sympathomimetic it's hyperactive. Anticholinergic usually they will have urinary retention. Sympathomimetic they don't have urinary retention. Okay, this is the three main symptoms that we can differentiate between the two syndrome. Let's talk about this case. Okay, case 3, we have a 32-year-old woman brought to the emergency department with her husband because of tremors, restlessness, and fever that began a few hours ago. He mentioned that she has a history of depression and migraine. 2 days ago, her psychiatrist increased her dose of antidepressant, and today she took the migraine tablet for severe headache. On arrival, she appeared anxious, diaphoretic, and confused. Vitally, she is tachycardic, hypertensive, hyperthermic, and tachypneic. Skin is sweaty and flushed. Pupils are dilated. Neurologically, she is having tremor, hyperreflexia, and clonus is noted. Which is the following is the most likely the cause of this presentation? Is it A, neuroleptic malignant syndrome, anticholinergic, sympathomimetic, serotonin, or heat stroke?
We have some answers. D, serotonin. One answer give us A, neuroleptic malignant syndrome.
Okay, so actually this is a serotonin toxicity. So what give it away? I think the clonus always give it away. If you have a clonus, you always think about serotonin. And basically in history is very the history is very typical history, increasing the dose of antidepressant or changing the antidepressant basically without giving an enough time for the medication to wean off from the body. Okay, so let's talk about serotonin syndrome. What are the xenobiotic can cause serotonin syndrome? Of course, um, uh, usually what cause serotonin is basically any drugs that can increase the serotonin concentration in the CNS. And usually serotonin syndrome does not happen if there's a single injection of these drugs. It's usually always, or let's say most of the time, there's a combination of a drug which cause the serotonin syndrome. One of I think the presentation that we have tendency to overlook is when a patient who present which a patient with psychiatric illness or depression, and they are on antipsychotic, and usually like they will present to the emergency with serotonin syndrome after changing their medication without giving them enough time for the previous medication to wean off from the body. So although they are on single medication, but because the effect of the previous medication is still in the body, the effect as if they are having two medications in the same time. Does that make sense? Okay, so what is the mechanism of action? It acts on the serotonin receptors and dopamine receptors centrally, and by this it mediates the hyperthermia. It also increases the muscle activities. Okay, let's talk about the mechanism. So there is different mechanism of what can increase the serotonin concentration and the neuroleptic on the centrally. So what can increase the serotonin concentration centrally is anything that will lead to that will increase serotonin formation, such as tryptophan. Anything will increase the serotonin release, such as amphetamine, cocaine, and mirtazapine. Keep in mind that stimulant and sympathomimetic can give you serotonin toxicity. Okay, anything will decrease serotonin metabolism and breakdown of serotonin, as such as the MAO such as the siliglene, methylene blue, linezolide, and phenylazine. Anything will increase the serotonin receptors agonism, such as bispirone, triptan, which actually in our case, our patient, this is what she ingested. She ingested triptan for her migraine, fentanyl, lithium, anything that decrease the serotonin reuptake by decreasing the reuptake, you are increasing the serotonin concentration, such as SSRI, SNRI, bupropion, tricyclic antidepressant, ondansetron, cyclobenzapine. All of this can actually lead to serotonin syndrome. Let's go next. So what are the symptoms, and what other symptoms would you expect? There will be mental changes, autonomic hyperactivities, and neuromuscular abnormality. This is very important when we talk about serotonin. What I want to emphasize is that keep in mind that serotonin is not like it has like a scale of severity. So it can present with very mild symptoms, but still you can say this is serotonin syndrome, and it can present in a severe symptoms, and still this is called serotonin syndrome. So what I mean that not all of these findings are consistently present in the patients. So when it comes to diagnosing serotonin syndrome, we can use Hunter criteria. So in Hunter criteria, if you can notice here, you can see that the presence of serotoninogenic agent is very important, and it should be either a recent addition or increase in dose or overdose, or there is an interaction of these drugs. So this is in the history, this should present in the history to say that maybe patient have serotonin syndrome. And then with this, you should have what? You should have one of the following condition, not all, keep in mind one, to say this is serotonin syndrome. So why did I included serotonin syndrome in hyperthermia or in toxin-induced hyperthermia? Is because in severe serotonin syndrome, it can cause hyperthermia, and that's why hyperthermia is the main things that would kill the patient or increase the mortality of the patient. But not necessarily all serotonin syndrome will develop hyperthermia. This is very important to understand. So as you can see here, the criteria is spontaneous clonus with the presence of ingesting a serotogenic agent is enough to say that you have a serotonin syndrome, or inducible clonus with agitation or diaphoresis. You can see either or ocular clonus with agitation or diaphoresis. Here, ocular clonus or inducible clonus plus hypertonia and plus temperature of more than 38. The other is, even if you have only tremor with hyperreflexia, you can say this is a serotonin syndrome. Okay. Let's go next. So what is the management? Of course, the management is removing of the precipitate agent or stopping this precipitate agent. Supportive care, of course, you administer IV fluid, stabilize the vital signs. Of course, you will control the agitation with benzos, and then autonomic instability as well. You control it. If you need to put patient on beta blocker, then you can start beta blocker, and control hyperthermia, which it is very important, and we'll talk about it later on. Okay, so usually, like, it's an old practice, I would say. They used to give cyproheptadine, but anyway, it's not really recommended anymore. Instead of cyproheptadine, although some hospital they do have cyproheptadine, you can give benzos. It's more available, and I think people are more comfortable using it, and it has the similar effect. Okay, let's talk about this our other case. So we have here a 45-year-old male brought to the emergency department with his family after he was seen very weak, confused, and febrile for the past 1 week. They mentioned he has recently started a new medication for his psychiatric condition about 3 weeks ago. On examination, he appears lethargic, sweaty, and mumbling incoherently. He's hypertensive, tachycardic, hyperthermic, and tachypneic. Physical examination, he's diaphoretic, pupils are normal, there is generalized muscle rigidity, slow reflexes, and a laboratory finding later showed CK and renal impairment. So what is your diagnosis? What do you think this patient has? Okay, we have here B, NMS. Okay, good. So actually this is an NMS case. So what is the pathophysiology behind NMS? Usually the pathophysiology behind of NMS is decrease the concentration of dopamine in the receptors. This is what will lead to NMS. So this happens usually by especially by two groups, by either giving antipsychotic medication, which actually will inhibit dopamine, or by withdrawing of anti-Parkinsonism agent, which actually stimulate dopamine release. So usually the mechanism of toxicity is dopamine receptor antagonism. Anything decreases dopamine concentration in the brain will lead to the NMS formation. So dopaminergic receptors blockage will lead to the muscle tone and rigidity that which usually we see in NMS patient. And also centrally, because of the dopamine deficiencies, will alter the hypothalamic thermoregulation, leading to hyperthermia. And of course, because of the inability to lose the heat and increase muscle activities will both contribute to the hyperthermia. Okay, so let's talk about the extrapyramidal syndrome associated with what? So usually to diagnose NMS, you should have muscle rigidity with autonomic dysfunction, altered mental status, and hyperthermia. So to say that this is NMS, you should have these four things. But very important to keep in mind that maybe patient may present you early that still he did not develop the full pictures of this. Why I'm saying that? Because usually NMS happen gradually. It does not happen fast or quickly, similar to serotonin syndrome. That's why when it happens gradually, maybe patient develop muscle rigidity, he has some autonomic dysfunction and altered mental status, but still didn't develop the hyperthermia. If this patient was not promptly treated, he could go to hyperthermia, and what will kill the patient is the hyperthermia. So how would you treat the patient? It's very important you immediately discontinue of antidopaminergic medication or reinitiate the dopaminergic agent. So if the patient was an antiparkinsonism medication and you stop the antiparkinsonism, resume the antiparkinsonism. This is a very essential part of the treatment. Then it is extremely important to control the hyperthermia. You have to do aggressive cooling for this patient. Then, of course, you can give the bromocriptine, amantadine, which is to reduce the hyperthermia and the rigidity. You can give the dantrolene, which actually can reduce also the muscle rigidity. And in some cases, you can do actually ACT, which it's actually electroconvulsion therapy, because some studies showed that it can be helpful. Okay. Okay, so just quick comparison between serotonin syndrome and NMS. What I want to focus is that I mean, already this was explained. I'm not gonna spend more time, but what I want you to understand is that serotonin syndrome happen within minutes to hours. It never develop over days. On the other hand, NMS usually it happens very slow. It's usually develop within days to week. And when it comes to recovery, usually serotonin syndrome, they recover very fast. Within 24 hours, they will be doing well. Most of them, unless it was missed or not treated. In NMS, unfortunately, it has very poor prognosis and recovery takes weeks to months, actually. Okay. Okay, let's see this case. We have a 27-year-old man undergo elective surgery for a leg fracture. Suddenly, he became tachycardic, febrile, and during the procedure, about 20 minutes after induction of anesthesia, the anesthesiologist noticed that there was a rapid raise in his end tidal volume. And despite increased ventilation, the patient, he was tachycardic, and basically temperature also start to raise. Usually what medication was used in the general anesthesia? They used succinylcholine and sevoflurane. Vital signs: blood pressure. He was tachypneic. Sorry, hypertensive, tachycardic, hyperthermic, and tachypneic. Oxygen saturation is 92 with assisted ventilation. Physical findings: skin is warm, flushed muscle and rigid, especially at the jaw and the chest. Pupils normal, and capnography elevated CO2. And you notice that urine was dark. What is your diagnosis? Good, malignant hyperthermia. So malignant hyperthermia is a rare disorder that is associated with congenital. So keep in mind that malignant hyperthermia is a congenital disturbance of calcium regulation and the striated muscles. Okay, so if a patient had malignant hyperthermia, it means that he has this congenital abnormalities. So usually for a healthy people, you will never have malignant hyperthermia happening with any type of medication. It happens on only these few population. And the thing is that you cannot screen them for this. This is the problem. You cannot screen people and say that, oh, these patients having a risk of malignant hyperthermia, because it's a genetic mutation. But it can happen when when patient get exposed to this agent. So usually xenobiotics is the most common is volatile anesthesia and depolarizing muscle relaxant, such as succinylcholine. Let's talk about the mechanism of action. So basically what happened is exposure of this anesthesia will lead to depolarization, muscle relaxant, or really severe exertion precipitating uncontrolled calcium efflux from the sacroplasmic reticulum, leading to severe muscle rigidity and hyperthermia. So when we give dantrolene will inhibit the calcium efflux, and by this it will cause the muscle relaxant to happen by inhibiting the calcium efflux in the sacroplasmic reticulum. Okay, so sorry, let's talk about malignant hyperthermia. It is characterized by what? Muscle rigidity and hyperthermia, and it is associated with what? With autonomic instability as well. It can lead to rhabdomyolysis, acute renal failure, electrolyte abnormality, coagulopathy, metabolic and respiratory acidosis, and pulmonary edema, and eventually death if it was not treated. So what is the management? Management, of course, it is early administration of dantrolene to inhibit muscle contraction, and of course, managing the hyperthermia by external cooling. Okay, let's talk about this. I think this is our last case. So we have a 24-year-old woman brought to the emergency department after her roommate department by her roommate after she was found confused, breathing rapidly, and complaining of ringing in her ears. The roommate reported that the patient has been depressed. On arrival, the patient is agitated, flushed, and sweaty. She repeatedly says she feels hot and dizzy. Vitally, blood pressure is 100/70, normal. Heart rate is mildly tachycardic. Temperature is hyperthermic. She is tachypneic, and saturation is maintained on all room air. Physical examination: she is warm, diaphoretic. Pupils are normal. Lungs are clear, but there is a deep, rapid respiration. Neurologically, she is confused and restlessness. And there is mild epigastric tenderness. This is your laboratory findings. Which of the following best explain the patient presentation? Good. Most of you are saying salsarate. So it is salsarate toxicity. So let's talk about the uncoupling of oxidative phosphorylation. So uncoupling oxidative phosphorylation, usually it happens in a few drugs. The most common is salsalate overdose, and it can happen in PCP and dinitrophenol. Dinitrophenol is not anymore used actually as a drug. PCP is fungicides that it can be used, and sometimes it can be an adulteration of illicit drug. But usually, the most common that you can get and exposed to is salsalate overdose or aspirin toxicity. So what happened is what caused the hyperthermia here is because of uncouples of the oxidative phosphorylation in mitochondria and inhibit the coupling between the electron transport and phosphorylation reaction, and this will inhibit the ATP synthesis. So I will just go briefly about it. So what happened is that in oxidative phosphorylation, you have here, this is the oxidative phosphorylation that happens in the mitochondria in every cell, basically in the body. What happened is that you have four complex, that these complex, like complex 1, 2, 3, and 4, these four complex are responsible for what we call oxidative phosphorylation. And this, when this series happens, like electron will be passed from one complex to another. It will activate the release of hydrogen to be more concentrated inside or between the two membrane. This activation of hydrogen ion will stimulate the ATP synthase. To push the hydrogen inside, and then the formation of ATP by ADP. So what happened is that there will be a dissociation between the four complex and between the ATP's synthase through the uncoupling of phosphorylation done by the aspirin and aspirin or salsalate or PCP in severe toxicity. And this disturbance will lead to what? To heat production and the production of lactate and shifting the metabolism to anabolic metabolism. I hope that explained it, although يعني, it is very complicated. It needs further explanation, but I really cannot go in details because of the time. So let's talk about what signs and symptoms to expect. Usually for the PCP, you will have tachypnea, tachycardia, diaphoresis, hyperthermia, and like hypermetabolic state. When it comes to the salsalate, you will have ringing of ear. You will have high temperature. You will have nausea, vomiting, lethargy. You can have hyperventilation and respiratory alkalosis. You can have metabolic acidosis and seizure. So what is the treatment? Of course, when it comes to the PCP, it's usually managing the hyperthermia, and it's usually supportive treatment. And there is like some, role of exchange transfusion, but it's not really, that doesn't have a strong evidence, but it can be used if patient really sick, like in a sick condition, then you can try the exchange transfusion. When it comes to salsalate, the main treatment is sodium bicarb, of course, treating the hyperthermia, and then, of course, hemodialysis if it is indicated. Okay, I'm not going to go through other causes of hyperthermia just to keep up on time. Just going back to our case, I like that most of you were able to answer what cases was. Actually, it was an NMS case. And unfortunately, our patient developed multiple organ failure. Did not really ended up doing well. Okay, so I'm not gonna talk about the case. Let's talk about the cooling methods. So I just want to focus here about the cooling methods. Okay, so what would you, okay, this is just a question. What would you use for a cooling method? Are you going to use water immersion, evaporation by using mist and fan, or by ice packing? Or cold saline? Okay, we have immersion. What else? Okay, we don't have much answer, but okay, let's talk about it. I'm going to talk about, the cooling methods briefly, but I would cover the most important things that you need really to cover. So I'm not going to go through the papers just to keep up on time. What I want to emphasize here, there's multiple papers done, and basically these papers are really important and interesting because based on this paper, which actually we call them toxicology classic paper, that our practice came to date, we came up into our practice these days, is based on this paper. But I don't want to go through this, but what I want to emphasize as the result of this old paper, okay. Okay, this is what I want to emphasize is that water immersion is superior. However, water immersion, there is too many limitations to water immersion, although it is superior in lowering the hyperthermia. One of the things is most of the emergency department do not have water immersion or water tap. I mean to do the immersion in it. One thing. The other things is you cannot really use it if you have severely sick patient, severely agitated, or patient requiring ventilation. So this is the limitation of water immersion. One thing. The other things is that I would say as an alternative to water immersion, what you can do is evaporation. Evaporation is by what? What I would say, remove patient clothes, go get a bed sheet, soak this bed sheet in a cold saline or cold water, just tap water. You can use the tap water and then put it on the top of the patient. And then what you can do, you can put an ice pack placed on where? Placed on the major vessels such as the groin area, axillary area, the neck. And then also you can add on top of all of this, you can add a fan just for fanning, to increase the heat evaporation. And every time that you notice that the patient body is becoming hot, you can spray the patient with cold saline, spray the bed sheet itself, and by this you can actually start cooling the patient. And the other things I would say is that just how many of you, this is just a quick question, how many of you would give cold saline? just share your thought on the question and answer. Okay, I would give cold saline, good. Yes, active cooling, okay. Who else would give cold saline? Okay. So basically the things, okay, so I will give a cold saline. Okay, so the things is, to be honest, cold saline has no role it's not part of the hyperthermia management. Let's say that. Although you can give a cold saline, I wouldn't say that you shouldn't give or it's contraindicated. But what I would say, which is extremely important for whoever like attending this webinar, is that external cooling is your main treatment, not really giving a cold saline. This is one thing. So what you want to initiate is this external cooling. This is very doable. This is very achievable in every emergency setting. Is cooling the patient in this way by putting ice pack or by putting a cold pack on this region, and by putting a bed sheet on the patient surface. Of course, before placing the ice pack, you should put some surface in between the skin and the ice. Okay, you can give the fluid if you want, but it is not really a real part of the hyperthermia. But it's not contraindicated. You can use it, I would say. However, keep in mind that most of these patients are not heat depleted. Oh, sorry, are not fluid depleted. What does it mean? It means most of these patients, you don't really need to give them massive amount of a fluid because you think they are heat depleted. They are not. Most of these patients, they have abnormal regulation of thermoregulation, and that's what making them hyperthermic, not because they lost a lot of fluid, even, and this also apply on heat stroke, by the way, although you will think that they are heat depleted, but not all of them. And this is came from where? From one of the studies that was done actually in Saudi Arabia, where actually they wanted to monitor the central venous pressure. It was done in the Hajj season. By the way, many of our studies in hyperthermia, managing hyperthermia and heat stroke, came actually from the Hajj season. And this was the first actually studies that done. So here, what they found actually only one third of the patient has low CVP and low intravascular volume. One third actually had normovolumic, they were normovolumic, and one third, because of their comorbidities, the heart failure and renal failure, they actually were having hypervolemic. They were in hypervolemic state. Keep in mind, all of these patients were diagnosed with heat stroke. Okay? So I want to emphasize, do not over give fluid. So what are the key points and what to take home is, keep in mind, when you have hyperthermic patient agitated, the 7 pathognomic mechanism that we just discussed, including 6 tox-related, and the 7th is the heat stroke. Managing and identifying the hyperthermia is the most important to decrease the mortality, and you can use as alternative to the water immersion, as you can use the evaporation techniques such as misting, fanning, and ice pack. Remember, not all the patients are fluid depleted, and of course, call your toxicology. Okay, so I think Dr. Samia, done.
Thank you so much. Thank you so much, Dr. Afra, for this outstanding and comprehensive overview. I enjoyed a lot going for all this diagnostic algorithm to and differentiate or hyperthermic patient. This is really like practical and insightful. Thank you so much. We are running out of time. We can continue until 1 o'clock and 5 minutes because we started at around that time. And we encourage you to write your questions down. So we have initially now some questions. Let me start. The first question is the use of physostigmine in TCA anticholinergic precautions. The second, can we start the sodium bicarb bolus in salicylate poisoning before the lab and the VBG results? The third point is target temperature to stop cooling. Let me ask the audience about the third question. What's the target temperature to stop cooling, especially if you do the immersion? So any thoughts, right, please, in the chat. And for the first and second question, Afra, if you can elaborate on that.
Yeah. Excellent question for this anonymous. So basically what I want to emphasize here, when you have TCA toxicity, what will kill patient in TCA toxicity is the arrhythmia. So although patient with TCA can have anticholinergic syndrome, you don't really require to treat it with physostigmine. You need to address the TCA toxicity, which it is the arrhythmia, and you need to give sodium bicarbonate because of the arrhythmia. This is what will kill the patient. But why it is important to understand that TCA can cause anticholinergic? Because part of the anticholinergic effect of the TCA is that there will be urinary retention. So you need to keep in mind if the patient was agitated, that maybe they are agitated because they cannot pass urine, and that's what makes them agitated, and you need to insert Foley catheter. One thing. The other things is that if a patient with let's say TCA toxicity developed hyperthermia, although less likely because it has an effect on the anticholinergic receptors, but it is not that much big effect, you know. Let's say even assuming that they develop hyperthermia, your target is not giving physostigmine. Honestly, your target is giving is cooling the patient, giving external cooling. Okay, so this have been said. I know that many people, they think that, okay, it is contraindicated. It's not really contraindicated because the case that which was published, it was a case report was published, and a patient was given physostigmine and the patient seized, and later on he went to cardiac arrest. Basically, physostigmine was not actually it didn't have any role in managing that patient, because that patient was extremely sick patient with severe altered mental status, and that patient had already ECG changes at this point. So that patient died not because literally of giving the physostigmine. He died, or she died, I don't remember it was female or male, because of the TCA toxicity itself. Okay, I hope that this answered the question. So
Thank you. Yeah, thank you so much, Afra, Dr. Afra. The second question was about, can we start the sodium bicarb bolus in salicylate poisoning before getting the lab, the VPG results?
I would say no, because VBG will take seconds. Get the VBG. It doesn't take time, honestly, because
Correct.
VBG should be POCT. Get the VBG, confirm that this is salicylate toxicity, and then start sodium bicarb.
Yeah, great. We have responses about the hypothermia. It's 39. Yeah, correct, 39. Because if we go until 37, we will risk about the hypothermia and the arrhythmias that may cause by that. So this is
Can
good.
also go to 38.
Yeah,
38 is fine.
38 and a half. Yeah.
38 is
Don't.
your target.
Yeah. Yeah. But
Because
39 is optimal.
39 you can, but 38 is fine, because why we don't normalize the body temperature, because there is something called after a drop. So what it means after a drop, even after stopping the cooling effect, what happened is that the body temperature will start to drop further. That's why.
Yeah, great. Yeah, exactly. Excellent.
Okay.
The other thing here we have another question about the patients. What maximum benzodiazepam to be given? We titrate up until having the result. It's really important to titrate up. Benzos are safe if we are using them to control this stimulant effect.
I agree with you, Dr. Samia. There's no really
Yeah.
maximum dose. You can give as much as you can to achieve or to control patient symptoms.
Yeah, and also this is like a great opportunity to elaborate about the benzos, because sometimes the agitation is the source also of heat. So controlling agitation, we are controlling also the hyperthermia. This is
Excellent.
also yeah, important.
Yes.
Other point we have, yeah. Any other question? Yeah, if core temperature rectal unavailable, ear type is closest we can use. The point is rectal is the gold standard, because when you have the hyper stimulation, we will have the ear or other are not very accurate. So the rectal, we prefer the rectal.
But I mean, if it's not available and you have the ear and the patient is like having neurological manifestation with hyperthermia, then yes, you can go ahead and treat the patient as heat stroke or as like tox-induced hyperthermia.
Yeah, exactly. Like we correct it. Yeah.
Yeah.
Any other questions from the audience? We have only 2 minutes before we wrap up.
Okay, there is a question I think we missed. Oh, this last
Really?
answer, the maximum benzos to
Yeah.
give. Yeah.
Yeah.
Okay, so just to add, there's no maximum benzos, but however, if we are giving a massive amount of benzos and patient is not responding, then your second line of treatment, you can give like phenobarbital. And in severe cases, you can also consider like, sedating the patient. If this was sympathomimetic with hyperthermia, because keep in mind, hyperthermia, which will kill the patient.
Yeah,
So
exactly. And also, yeah, and phenobarbital is sometimes why it's a second line, because it's not the same mechanism of action as benzos. It will help the GABA to work even without the GABA receptor to work even in the absence of the GABA as neurotransmitter. So it's very highly active and also with long duration of action. So this is the second line. We are rapidly approaching our end of time here. This is like fantastic discussion. It has been.
thank you so much.
Yeah, thank
Yeah.
you. Thank you to our audience. Thank you for your time, your engagement, for this excellent questions and interaction with the cases and questions. This is like clearly a topic of great importance with all the syndromes, toxidromes important in the toxicology. And like this session has been recorded, and we will share this with you in the future for the
For anyone who want to access, all our webinars, it will be available on ESAM website soon. Even the previous one. Yes.
Yeah.
مع السلامة
Thank you
everyone.
so much. Yeah, this concludes our webinar. Thank you all for once again, and have a wonderful evening or an afternoon.